remember the question we asked at the beginning of the conversation? How high would you rank healthcare sector or the health sector under President Muhammadu Buhari in the past 5 years? Well, we have the implementers and of course the healthcare managers here with us in the studio to give us insight. Let me quickly introduce first of all the Honorable Minister of Health, Dr. Osagie Ehanye. Thank you very much for joining us.
Good morning.
And let me also welcome to our studio Professor Mohammed Nasir Sambu, who is the Executive Secretary of the National Health Insurance Scheme, NHIS, a very popular scheme here in Nigeria. I'm sure Nigerians are happy to have you with us.
Good morning, viewers.
All right, and also with us here in the Abuja studios is Dr. Faisal Shoaib. He's Executive Director and CEO of the National Primary Healthcare Development Agency. Dr. Shoaib, delighted to have you again on Good Morning Nigeria.
Thank you for having me. Good morning, viewers.
All right, and another guest who will be joining us for this conversation, of course, is a familiar face now on Good Morning Nigeria. He's the Director General of the National Institute for Pharmaceutical Research and Development, NIPRIT, Dr. Obi Adigwe. Dr. Adigwe, delighted to have you with us this morning.
Kieran, and it's my pleasure to be here to talk to Nigerians this morning.
All right, gentlemen, once again, I'm delighted to have you with us on the program. Let's begin the conversation with the Honorable Minister of Health, Dr. Osagie Ehanye. Dr. Ehanye, I mean, we are having this conversation now under the cloud of the coronavirus pandemic, and the temptation is always very strong that our experience in seeking to combat the pandemic has, of course, revealed the vulnerabilities that we have in our healthcare system. So that could be almost an immediate takeaway. But realistically, we can reflect on the 5 years of the Buhari administration and keep a track, as it were, of the milestones in the health sector. And happily, you've been with President Muhammadu Buhari for almost 5 years. You came in first as Minister of State in 2015, November 2015. And last year, of course, you became full, shall we say, substantive Minister of Health. What have been those defining issues in the health sector under the Buhari administration?
Well, the defining issue, you can say, is universal health coverage, and that is what the World Health Organization and the United Nations have also placed as a very immediate and urgent need, not only for Nigeria, but globally. How to achieve universal health coverage? First beginning with primary health care that should be offered to all citizens. Nigeria has a target to be able to offer primary health care to citizens, at least 80% of citizens. You begin that with infrastructure. You need a whole set of infrastructure. The policy has been to aim for one primary health care center per political ward, and aim for one general hospital per local government, and at least one tertiary hospital per state. And that has been the policy that's going on. We have at least about 40,000 primary healthcare centers. Now, recently we created a new design of what a primary healthcare center should look like. That means that many of those functioning now, we need an upgrade that will make them functional around the clock. You have 24-hour service, and even in rural areas, if you have solar power given, and if you have water supply, and you have staff quarters, then you can offer service around the clock.
Well, I would tell us that this where the if you like, the strategic plan to ensure that the health status of the country improves. I recall on Good Morning Nigeria a couple of times we discussed the rollout plan for the primary health care centers. If the original idea was to have one per ward and then have another set per local government and tertiary health care per state, what are the numbers indicating? Did we achieve these goals?
Well, the way the health system is structured actually places primary health care in the realm of local government, secondary health care in the realm of secondary, and the tertiary health care in the realm of federal. But there is collaboration across these lines, across the tiers, in the sense that the federal government recognizes the importance of primary health care because that is the foundation of healthcare. That's where it begins. And if you have a very functional primary healthcare system, taking care of all the most common disease burdens, you will have actually taken care of 60% or more of your entire problem in the health sector. So the federal government invests heavily in the primary healthcare system, provides money for infrastructure, and recently the Basic Healthcare Provision Fund to help to fund this area. So therefore there is a lot of attention being given to it. The area that has not fared so well is the secondary healthcare, because there has not been much investment in secondary healthcare, and that secondary healthcare should actually be the referral center for primary healthcare centers. The private sector is what has largely been filling the gap for secondary healthcare, because right now people require healthcare either go straight to the teaching hospital, to the tertiary hospital, or they are referred from primary healthcare to the teaching, skipping the secondary level. So that system needs to be restored, needs to be rebuilt, so that you have a uniform service delivery system. And connecting all of them should be a functional ambulance referral system, ambulance transportation, and also emergency treatment system that should be able to move patients even from their homes to healthcare centers.
Okay, Honorable Minister, bringing healthcare, affordable and quality healthcare closer to the people, it's a familiar phrase, I mean, among health implementers and healthcare managers. We've heard in almost all statements that's always the objective. I'd like you, since we are reflecting, I mean, reviewing 5 years of achievement with indicators or indices, give this phrase a context.
You've said the right words, bringing healthcare closer to the people. And that is exactly what the primary healthcare system is supposed to do. If you have to go access healthcare at a major hospital, the transport cost alone is a deterrent. So and that's the reason why we are making a primary healthcare to be more comprehensive, to be able to offer you service not only close to you, but also when you need it. As it is now, you have a primary healthcare center that works from maybe 9 a.m. to 5 p.m. What happens if a lady is going to deliver at 2 a.m.? That's a problem. So you have a lot of issues that arise due to the fact that you cannot have access, or you have access but you do not have the service around the clock when you need it. Because as they say, illness will not give you warning every time. So you have accidents, you have deliveries, you have children who fall sick at odd hours. So they need to be able to have service as and when they need it and close to the house. But then another important feature is that when you don't have transport at odd hours in rural areas, how do you move a lady who has had a delivery at home and is bleeding and it's 2 a.m. and there is no transport? How do you move them? How do you get them to a hospital? So that is an addition to the maternal mortality rate, just the lack of transport alone. So an ambulance system that you can call, that you can dial a number that you know, that can pick you up from your home and take you to a health center to where you can get your treatment without wasting time, will add to the value of the health system. And that's what we are working on, to create a system like that.
Sorry, you've talked about access and services. In terms of indices, let's look at maternal health, for instance. Let's look at child and infant health, for instance. When MDG was being implemented, the MDGs, we gained some grounds in terms of the indicators, per 1,000 live births and all that. What are the indicators reading as at now?
Well, there has been slight improvement according to a last survey. The Population Commission had done a survey which showed that there has been slight improvement. And there are, in some of the programs, there's been improvement. Malaria prevalence, for example, has dropped from 42% to 27%. HIV has also dropped from 3% to 1.3%. So there are some improvements there, but we believe there's room for further improvement. There's plenty of room, and if we manage our resources properly, and if we also manage our human resources and material resources, and we have innovation in the way we apply resources, then we can do a lot better than that.
I'm just wondering, Honorable Minister, I would like you to drill further into the general concept of universal health coverage as a key objective in the health sector of the Buhari administration. Other than infrastructure, which we talked about, primary health care, general hospitals, and tertiary health facilities, tell us something. Was it also part of the agenda, for instance, to focus on the development of quality trained manpower for the health sector? That's one. Did they also focus on cost in terms of access to healthcare services? And thirdly, did it also focus on medicines, availability of medicines, and the safety of those medicines?
Yes, very good. That's a very good question. The first one is on human resources. Every primary health care center, of course, has to have its human resources. You have to have a doctor, if possible. If it's a very urban area, you can have doctors. If you have very rural areas, you might have a nurse or head in it who is knowledgeable enough and will support staff, community health extension workers, and all those. But one of the problems we've had in the past, the way we managed our hospitals was to have a central pool of workers where you transfer people to various areas where they don't want to go to, which looked like conscription. But we're looking at a model where we go to the communities and select people who we take in for training, either as community health extension workers or even as community health influencers, train them and then send them back. So the attrition, if you have a manpower that's derived from that method, the attrition is much less. You can have more human resource presence. But the experience is that if you employ someone and you post him to one place this week and in 3 months later you post him somewhere else, the way we see frequently done, there's a lot of attrition. They don't show up for work. Some show up for one day in the week and disappear, and the day they are there, they are bad-tempered and they are rude. So the service delivery quality is not good. So we are going to do on-site. We want to promote and encourage on-site recruitment, training, and then return to areas where they know the people know them, so there's familiarity. So that side of it is going to take, as far as access is concerned, as far as payment for services is concerned, the government, as you know, passed or rather is disbursing right now the Basic Healthcare Provision Fund, which is derived from 1% of Consolidated Revenue Fund by the federal government. We are encouraging state governments to also add money to it so that you can increase the fiscal space to be able to render service, buy medicines, assure vaccines, make sure that you are able to provide the services for labor, for maternity and child care, and all the things that you need to get a primary health center working. As far as medicines are concerned, we are looking, you will hear that very soon from the health insurance, we are looking at upgrading the services that are available, or rather that are promised at primary healthcare center, instead of merely just offering maternity and diagnostic alone, test of blood sugar and test of your blood pressure, but no treatment. We want to be able to offer treatment actually. That is the upgrade. That we will see that even in rural areas, if you are tested for diabetes, you are tested for hypertension, you can be put on medication, and that advantage of being able to make purchases at high quantity will stimulate the pharmaceutical industry, the local manufacturing. So you create demand of drugs produced in Nigeria if you are able to actually spend in providing for the primary healthcare centers at that scale. So you are able to develop the pharmaceutical industry as well as you provide improved quality of treatment instead of half treatment. Diagnosing someone and telling them to go home is no treatment.
Okay, just before we expand our conversation and bring in our other guest, Honorable Minister, I know as of 2018, Nigeria is a member of G8 countries that are collaborating in terms of universal health care provision, including some Asian countries. At one of their events last year, we got to know that Nigeria was doing about 70% universal health care coverage. I don't know if I'm right, if we've gone up that now. Are we doing more than that now?
70%, I don't think we're up to that.
We are not up to 70%, fine. So, but there were schemes, initiatives, put in place to shore up, our achievement in this area. I'm looking at schemes like the midwife service schemes. I'm looking at schemes like the skilled, bed attendants that are supposed to assist to provide some form of intervention, where, we have gaps and all that. And there's also the immunization, coverage. What has happened to, these schemes? Are we still implementing them? What has been the input in terms of shoring up our universal healthcare coverage?
Yeah, that's correct. Those are all programs that we have planned, and the programs are working well, some not so well. There are certain issues in the way they are designed. The immunization program has been doing quite well, relatively speaking, compared to the others. Coverage has improved. As you know, Nigeria has been declared polio-free. That is also thanks to the very efficient delivery of immunization at that level for that particular antigen. And we are working hard on all the others. There's been a sort of a downward trend now since the COVID came in because of focus or fear on COVID. But as for the other schemes, if you have the midwife service scheme, for example, it required quite a bit of funding, which was becoming scarce. And there was also a question about, well, if the compliance was not always very easy, if you recruit somebody from one place and take him to a place that's far away, where he's far away from his family or from their family, whether the attrition was not going to be too high. But on the whole, the funding was a major problem for that particular scheme. And but what we are looking for is to be able to increase the productivity of people who are recruited by placing them near home, near their own home, so they don't feel the need to go away for the weekend and leave the place barren. So if they are near home, they are better. Secondly, we want to create residency, staff quarters at the primary healthcare center, so that you don't have a long way to commute.
Are they still in the planning stages, or are they on the are we about to begin the implementation stages?
Yes, we have a new design. We have actually a model of what the primary healthcare center should look like, a model, architectural model, complete with solar power, staff quarters, and the borehole.
Is it the one at Kuchigoro? The one that was...
Well, that's a model, yes. But we have a model, table model, which we are going to be publicizing for those who want to build primary healthcare centers. That this is what you look at, comprehensive. It has all the features that you would like to see in a center that is offering real service around the clock. So that architectural model is what the Primary Healthcare Development Agency has brought up, and we are going to propagate and upgrade the ones that don't have all these features as yet, all these facilities and utilities.
All right, Honorable Minister, thank you very much. I mean, while we're still on the issue of primary health care as part of the aspects of the health sector, let's bring in now Dr. Faisal Shuaib, who is the Executive Director and CEO of the National Primary Healthcare Development Agency. Dr. Shuaib, I mean, there's no question about it that you want to display the trophy of Nigeria defeating white polio virus as a major victory for us in this country. But what else has been heartwarming in 5 years of the Buhari administration, with particular focus on primary health care?
Yeah, thank you very much. Yes, just talking about the achievement of white polio virus free status, I'm sure brings a lot of warm feelings to all Nigerians. I'll say this is another moment in the lives of all Nigerians where, you know, we've come together and defeated a very ancient disease. And this really comes down to leadership, the leadership that has been provided by President Muhammadu Buhari, by the Honorable Ministers of Health, and really leadership at different levels, leadership from our development partners, our donors. I want to call out, you know, I want to specifically appreciate Mr. Aliko Dangote and the Dangote Foundation, whose collaboration with the Bill and Melinda Gates Foundation really helped us cross the finish line. But when you talk about leadership, I think the leadership of President Muhammadu Buhari in 2016, when we suffered a major setback in terms of finding white polio viruses in the Northeast, was very, very critical, because at that point staff of the Ministry of Health that had worked so much over the last 30 years, staff of the National Primary Healthcare Development Agency, our development partners, were really you know, depressed because of this setback. But he showed leadership by calling the troops together and say, even after the first few cases, go and find more cases, and here is 9.8 billion naira to make sure that we do not make this a protracted war. And this is exactly what we did, pulling everybody together, motivating everybody together. And you know, yeah, you're absolutely right that we're very excited. But beyond polio eradication, one thing that we've also seen since the Buhari administration is a return in terms of confidence that our donors have in the system, because they know he's transparent, he's incorruptible, so they can now see very, very clearly that whatever funds they put in the system will be judiciously used. And this is exactly what is happening. So around 2015, 2016, you may have 2015, 2014, you might have recalled that there were issues around accountability in the use of funding from the Global Fund, from Gavi. But since the advent of this administration, we have seen more than $1 billion in investment, specifically in immunization and primary healthcare, because of the confidence that donors have in the system. But beyond that, how has that translated to the common man in the village, the common man in our community? In 2016, when there was an independent survey to see how well we're doing with routine immunization, the pentavalent 3 coverage, one of the antigens of routine immunization that is used as a marker for how well we're doing in terms of routine immunization, was measured, and we had only 33% coverage as at 2016. Within 3 years, by 2019, by the end of 2019, last year, when this similar survey was conducted, we had more than doubled the numbers, more than doubled the coverage. So we're now at 67% from the most recent SMART survey. That is huge and unprecedented, and our donors, our development partners are really excited about the kind of progress that we have made in making sure that not only have we increased the coverage in terms of the antigens protecting our children, but in terms of equity, making sure that those who have been left behind for so many years are now being reached with life-saving vaccines. Those are progresses that we have to be very proud of. These are the types of things that we may not shout about every day. These are the things that may not make the frontline pages every single day. But these are slow and gradual, unprecedented progresses that we have to be very proud of in Nigeria. How do all of this fit into primary health care? The Honorable Minister has so eloquently mentioned how we're trying to bring primary health care as close as possible to where people live and work, making sure that in every ward we had one functional primary health care center. But apart from having one functional primary health care center, how do we make sure that because a Nigerian accesses care, he doesn't suffer catastrophic financial ruin? You know that most families are just one illness away from being very, very broke. What the Honorable Minister of Health, the Federal Ministry of Health, and our partners are all doing is seeing how we can use the Basic Health Care Provision Fund to provide a pooling of resources, including some funding sources from different areas. I'm sure my colleague, Professor Sambo, will elaborate more on that. But by pulling all the resources together, it makes it possible that those that have are able to put money in a basket, so that those that do not have, the poorest of the poor, are also able to access care without paying so much money out of pocket. Right now, over 70% of Nigerians are paying out of pocket for healthcare that they do need. With the Basic Healthcare Provision Fund expanding the space of insurance coverage, we're able to not only reach more people with quality primary healthcare, but we take very strong steps towards universal coverage, so that nobody in Nigeria will be denied care. Everybody will be able to access care where they live and they work. This is one of the most prominent gains of this administration, because President Muhammadu Buhari, for the first time in our lives, approved that funding, and that funding has already started flowing, so that no matter where we are, no matter where we work, every Nigerian will be able to have access. Now, when you look at the different parts of the health sector, you begin to see a coming together of all of these interventions. Right? Basic Healthcare Provision Fund is working. You are beginning to see a motivation, even within the Federal Ministry of Health. Human resources are very, very essential. When you come to the National Primary Healthcare Development Agency, you see hardworking staff. I go to work Saturdays, sometimes Sundays, and I see staff working around the clock, right? And when you ask them, you're putting in so much, and they say that is what public service is about, that we put in the best, and we are motivated because the environment provided by the Honorable Minister, the environment provided by the President is the kind of environment that pushes us to try and provide primary health care to the people that really desire it. We're not where we would like to be, but what gladdens our heart is that we're making steady progress. We're beginning to introduce even new vaccines. We're looking at how a disease like cervical cancer will now be reduced to the barest minimum, because in the next quarter, in the first quarter of 2021, we're looking to introduce the human papilloma vaccine. We're introducing rotavirus vaccine, so that it will cut down the number of children who die from preventable diarrheal diseases. So it's really an exciting time to be in the health sector, where you can see that more funding is coming from the Basic Healthcare Provision Fund. Our donors are bringing in money, and when our donors, our development partners, see that the funds that they're bringing into the space is being used judiciously and it's yielding results, like we're able to eradicate polio, we're making progress in routine immunization, and we're beginning to strengthen primary health care, they can see that we have been able to renovate close to 4,000 primary healthcare centers. We've been able to expand.
Dr. Shuaibu, let me, I'm sorry to interject, but yes. I have to put you on hold for a while. There's so many questions to ask on that primary healthcare. I don't even know where to start with you. The Honorable Minister talked about new models of primary healthcare centers. I'm wondering if these new models fit into the RRI, that was started in, I think, in 2017 or thereabouts. That's the Rapid Response Initiative that comprise building some 10,000 primary healthcare centers. But please, let me just put you on hold and bring in the Executive Secretary of the National Health Insurance Scheme. Yes, we've talked about out-of-pocket expenses for, healthcare, accessing healthcare. How has the NHIS helped in that regard?
Thank you very much. Since we are reviewing President Muhammadu Buhari 5 years in office, I think it is important to bring everything together by saying that when the government came into place, there was economic recovery gross plan, ERGP, which has articulated all the necessary things that government will have to do, including the healthcare delivery system. Then as a follow-up to that, the Honorable Minister of Health led the Ministry of Health to in the new vision of the government, which is delivering on government's priority 2019-2033. And out of that, there is what is called next level agenda. And then next level agenda, you have the health sector next level agenda, which has about 10 elements. And these are some of the things that the Honorable Minister and the ED of NPSCDA have explained. But coming specifically, if you look at that health level, next level agenda of the Federal Ministry of Health, the first item is achieving mandatory health insurance through as a gateway for universal health coverage. So the context of universal health coverage look at three major elements: improving financial protection, expanding access, and introducing new services. All the agencies of the Federal Ministry of Health will have to come to ensure the attainment of universal health coverage. There are agencies that are working from the supply side, like the National Primary Healthcare Development Agency, like the Federal Ministry of Health, like State Ministry of Health, who are supposed to provide the services, the needed platform for which services will be obtained. Then the National Health Insurance Scheme is a leader in terms of ensuring financial risk protection. And the whole mark of the financial risk protection is to ensure that out-of-pocket expenditure, which is very, very retrogressive in terms of healthcare, access to healthcare services, is addressed. And if you look at the box of the universal health coverage, the financial risk protection element is on the top, because once you are able to make funds available within the healthcare delivery system, there is a tendency that other two elements of universal health coverage can be expanded. You have more fund into the healthcare, there is a tendency for more services, there is tendency for more coverage, as we are going to see in the basic healthcare provision funds. So the hallmark is to ensure that you stop that out-of-pocket expenditure, which is 70%, which is put at the value of 70% in Nigeria now. So, the way you do it is through effective healthcare financing mechanism, which you will see in the National Health Insurance Scheme. The National Health Insurance Scheme has the basic element of ability to mobilize funds, ability to pull the funds, and ability to ensure strategic purchasing of healthcare services. Because the major problem with healthcare financing is when you don't have money at the time of getting services, you are bound to have the effect, to fall into the effect, whether you sell your asset or you get into incurring debt to cater for the healthcare. And in fact, when you have a situation whereby you have to sell one of your most precious assets, example in rural community, you have to sell your farmland for you to have healthcare services, you will go into a vicious cycle of poverty and disease. So the health insurance is a kind of arrangement that brings about people together, and you pull their risk and you pull their resources. Because if you look at the pattern of disease in a human population, it is in a way that none of us will be ill for the same particular element at any given point in time. It is spread. So as the time when Mr. A is well, Mr. B will be sick. So when you pull all their funds, you will now take the funds to take care of Mr. B at the point of illness. Then that is how you continue to go.
In terms of evaluation,
yes, ma'am.
In terms of evaluation, with regards to financial protection of those who access, health care,
yes, ma'am.
What would be your evaluation of the contribution of NHIS in that regard?
Excellent.
Just simply state, please.
Excellent. You see, the health insurance law, if you look at it, it made provision for the coverage of the formal sector, the private and the public sector at the initial stage. Yeah. So if you look at the performance of health insurance, it has been able to achieve close to 100% for the formal sector, which is the main catchment population of the health insurance. But if you cover formal sector, from public sector and from private sector, they constitute insignificant proportion of the population. And you might not be able to say that you have addressed the financial risk protection of the country.
But that has always been the case.
Yes, but this is what the new administration is saying. If you take the first element of health sector next level agenda, achieving mandatory health insurance, the first thing is to ensure that the law establishing the National Health Insurance Scheme is amended, and this is what the Honorable Minister is spearheading. And I want to tell you that we have gone very far. In fact, if not because of this COVID, by now we would have had a revised NHIS law that is made mandatory. The implication of having mandatory health insurance scheme is that all the funds from private sector will come into the common pool of the National Health Insurance Scheme, and it will have capacity for what is called cross-subsidization. Okay. Because the larger the pool in the social health insurance system, the more the ability to cover the population. So once we have that law amended, we now have a framework that can mobilize the fund for the health insurance. Then the next item is, what is the framework that you use to cover the entire population?
Let's put you on hold. Kingsley, I know.
Yeah, all right, Professor Mohammed Sambo, thank you very much there for your initial salvo. We will return to you in the course of the conversation. Let's bring you now Dr. Obe Adigwe, who is Director General of NIPRID. You see him there on the right side of your screen. Dr. Adigwe, we've discussed a number of issues with you on Good Morning Nigeria. We know that you've not been in office in the entire 5 years of the Buhari administration, but tell us something. What is it that is there in pharmaceutical R&D that gives us a sense, for instance, that we're anywhere close to achieving medicine security as a country?
Well, thank you, Kingsley. You're quite right. I haven't been here for 5 years. I've been here barely 2 years. But government is a continuum. And to answer your question properly, it will be good for us to first understand two things: the ontological position of this administration, as well as the baseline that this administration met and which it is building on. And basically, if you drill down to the very core of the ontological position of this administration, you would realize that two key concepts are very prevalent in how this administration views healthcare reforms. One is local manufacturing, and the second one is value creation. When the Honorable Minister of Health answered your question on UHC, he very clearly mentioned that the focus of this administration has been on ensuring that local manufacturing is brought to the fore. And in terms of local manufacturing, I can provide some insight into three key areas where this administration has made significant progress based on the ontological position that I mentioned earlier on. In the area of finished pharmaceutical products and APIs, significant progress has been made. In 2016, the fiscal policy ring-fenced 4 key areas for local manufacturers: production of anti-malarials, production of hematinics, production of antibiotics and alkaloids, because those 4 key areas were areas where this administration had undertaken studies and identified that local manufacturers had the capacity to satisfy national consumption. And so an import adjustment tax was put in those 4 categories. And a few years later, our preliminary research has identified that in those 4 categories, you're having close to a double-digit growth in the industries in these areas. And what that means is that you're having Nigerians using more of these products that are made in Nigeria, high quality products, affordable ones that are made in Nigeria, but at the same time, the factories that are producing those particular categories are also employing more people, leading you to job creation, generating more revenue, both for the people who own the factories, the people who work in the factories, and for government that collects tax from the local companies that have those factories. So that's a good example as to how one fiscal policy of this administration has had a resultant effect both on the healthcare of Nigerians as well as the socio-economic development of the country. Another area where this administration has begun to put in a lot of emphasis that speaks directly to medicine security is the area of local production of APIs, that's active pharmaceutical ingredients. A few months ago, when COVID-19 hit India, one of the first things that they did was that they started looking at limiting their export of APIs to countries across the world. And if there is anybody, any country that hasn't started thinking seriously as regards how they would start to put together a framework for developing or manufacturing APIs within their country, frankly, that country isn't the country that's taking medicine security seriously. So it will please you to know that this administration has also taken that API discussion very seriously. At NIPRID, the agency which I am the Director General of, we have already started putting together a demonstration laboratory for producing APIs in Nigeria. We have already started opening up discussions with the NNPC, with Dangote refineries, as regarding leveraging the petrochemical availability that we have here in Nigeria and ensuring that value is created from that sector to produce APIs. Our API laboratory is also put in place so that we can use it to train academics as well as train industry practitioners in the importance of ensuring that local production of APIs is mainstreamed. The other area where this current administration has made significant progress is in the area of phytomedicines. As you very well know, whenever the president talks about interventions, he would always say, look inwards. And if you're a smart director general, if you're putting up projects, you will make sure that your projects or your programs align very closely with your principal's ontological position. And that's exactly what we've done at NIPRID. So we've developed what we call the contextual processing protocol, which focuses on harnessing the rich flora we have across the 36 states of Nigeria and ensuring that these particular natural resources, that there is a framework that can enable the harvesting in a sustainable manner, the processing, as well as the packaging for local use within the country and even possibility of export. And so one of the areas where we've actually gone very far on the CPP is our eucalyptus project with Kaduna State. And it will please you to know that we've gotten to the stage where we've now developed a business case and feasibility study based on technology that was developed and contextualized in NIPRID that will enable Kaduna State harness its over 6,000 hectares of already existing eucalyptus to ensure that these products can be brought into the Nigerian market rather than having them imported. The third area where I'd like to shed some light as regards the current administration's efforts in ensuring medicine security is in the area of vaccines. For decades now, Nigeria had totally lost its capacity to produce vaccines locally. And I think it was either shortly before this current administration came into office or shortly after they had come in, we had a big outbreak of meningitis. And that particular outbreak exposed the significant weakness weakness in the medicine security concept as it applies to the vaccine sector, because we literally went around the world looking for people who would sell meningitis vaccines to us, and we couldn't find. And so what this administration did was that it put together a framework for a robust engagement between government and private sector as regards developing a comprehensive and robust capacity to manufacture vaccines locally. And in fact, you can see with the COVID-19 discussion, that has now been brought to the fore. So what the government was doing a few years ago when it had started partnering with a local company as regards producing vaccines in Nigeria was actually foresighted, because currently I'm aware that government has now put its money where its mouth is and has signed a strong agreement with a local manufacturer to produce vaccines here in Nigeria, and that very vaccines production company has made some progress. So what it means is that when we're talking about vaccines, whether it is in regards to COVID or any other disease that that vaccines can make an impact on, we're not starting at ground zero. We at the very early stages of this administration, that need had been identified and various strategic actions had been put in place to address those particular needs. And just before I hand back to you, Kingsley.
Dr. Adigwe, I'm sorry, let's just put you on hold again. I'm sorry, I'm putting all our guests on hold. I'm the one that is having to put them on hold. I'm sorry. We'll come back to you, because I'm sure that Nigerians would want to know whether, because you've talked about, robust framework for achieving, our objective, which is fine, but we'd also like to know whether we have been able to move away from depending on international intervention for our pharmaceutical needs. But you will respond to that when we come back. We want to take a short break now, and the program will continue in a moment. Don't go away.
Wetin be this coronavirus thing? Na true?
You see this coronavirus wey be COVID-19, na the whole world palava o, and e don dey kill many people for China, Italy, UK, US, Spain, and even for other countries dem.
Okay, wetin come be the reason wey dem say make everybody tanda for house?
Na because if e dey waka pium go carry am from person wey don get am, you go carry come give your family dem. Na so the thing take dey kill other people for other countries.
Okay, wetin come be that social distancing sef?
You see social distance. Now make we no come close because this thing na from air and touch now we dey contact am. We suppose dey at least 6 foot away from each other every time.
So okay, no be only to wash your hand and to sanitize am alone.
Make we no take this washing of hand thing take play but make we come together, join hand as we take pursue Ebola, pursue this coronavirus. Make we be each other keepers now.
This message is brought to you by the Nigerian Television Authority, NTA, Africa's largest television network.
Welcome back to our conversation segment on Good Morning Nigeria. All our 4 guests are still here with us in the studios. Let's once again bring in the Honorable Minister of Health, Dr. Osagie. Honorable Minister, I mean, it's impossible to discuss health outcomes without reference to 2 very worrisome phenomena in Nigerian health sector. One, fake and counterfeit drugs, and the other, self-medication. How have you tackled this, or is it on your radar?
Oh, thank you. The question of fake drugs has been a big problem in our country, and you have that coming up in the shape of drugs that are either they do not contain what they are, the dosage they are supposed to contain or said to contain, or are totally just containing 0. That is why NAFDAC is there. NAFDAC handles that particular part, and they go on inspection and licensing. Any drug that is used here is actually supposed to have been examined, tested, and licensed by NAFDAC. If it has no NAFDAC number, it is fake. There are also some drugs that, as a matter of fact, also have fake NAFDAC numbers. People are ingenious, they put fake numbers on these drugs. So NAFDAC plays a regulatory role, but also plays a detective and police role in order to be able to tackle fake drugs. Self-medication, well, that is a bigger problem in the sense that there are people who think that if you are sick, you know what's wrong with you, and they immediately go to a chemist and buy what they need to get. Well, with simple medicines, it's not as dangerous as with very complicated things like antibiotics. And the reckless use of antibiotics in self-medication is part of the reasons why we have the global antimicrobial resistance going on now, and of great concern, because if you have weakened the power of the antibiotic, the day you need it, you really don't have an effect. So that is also something that is being very closely addressed in the countries that are well developed. There are certain medicines, category of medicines you can get, which are called the OTC, over the counter, and then the others which you can't get except with a prescription. But we are looking at a stage where we can reach that level. We need the cooperation of pharmacists, we need cooperation of the pharmaceutical society and regulatory bodies to make sure that medicines that are supposed to be strictly prescription medicines actually are given on prescription and shouldn't be available for anyone who has a few naira to buy. And there are also the issues of people who go to a pharmacy and buy a few capsules of ampicillin, which actually is not a full course of treatment, but there's someone who will sell you that, and actually again create a huge problem. So you don't even solve your problem, and you waste your money, and you create a problem of resistance. So those are issues that are of great concern, and they are definitely going to be given priority in addressing.
Yeah, Claire, thanks. I just we can take off from there.
No, are you still on counterfeit drugs?
No. I think the Honorable Minister has given an indication, but it just when he said that they will need the cooperation, that's to say the government will need the cooperation of the pharmaceutical society. Are there any protocols already on the way to ensure this? Because I mean, the commonest experience is, and I know that you have this rivalry in the medical profession, where physicians and pharmacists, or pharmacists trying to play the role of physicians. You walk into a pharmacy and you explain to the pharmacist who is on duty what's wrong with you. Say, don't worry, hold on. It goes to the chef, brings out one or two things, and then just gives you the prescription. There you go away. So, but it's so common in urban areas, and it's worse, of course, in the rural areas where you have quacks who are going about with all kinds of ampoules and then injecting people. Exactly how are we focusing on this? Because it's, as you very well know, it's one of the major causes why complications arise from some ailments, and by the time they are presenting, it's almost terminal.
Yes, you're correct. That's perfectly correct. That's why I say we need the cooperation of the pharmaceutical society, because much of the supply side of pharmaceuticals goes through their hands. And if they apply their own real ethics, they should not be allowing persons to collect medicines who have not been given a prescription by a doctor, and they themselves should not be dispensing medicines without actual medical examination and a diagnosis. And they're also making these medicines available as if they are just ordinary commodities. There are patent medicine stores that are normally able to dispense over-the-counter drugs that are not prescription drugs. But then again, if you go to some of them, you find really potent medicines which they are not supposed to have in their possession, which somehow they get their hands on. So all these regulatory functions, which should be pharmaceutical council with the support of the pharmaceutical society, we need the support and the strengthening of those systems to be able to control drug misuse and drug abuse. As you know, the drug abuse is also a problem that leads to addiction and so on when it comes to psychotropic drugs.
All right, thank you, Honorable Minister. Let's bring in Dr. Shuaibu. Doc, again, let me also congratulate you on the polio-free status. It must have come with quite a lot of hard work, commitment, and dedication. But we're still battling with other, diseases. Lassa fever is there, cholera is still there, meningitis is still there. Which brings me to my question. I'm wondering why it takes us time to curtail some of these diseases. What are the issues, that we're having to deal with? Is it issues of maybe expertise? Is it that of surveillance? Is it, I don't know.
Right, yes. Congratulations is to every Nigerian, and it's not just the Federal Ministry of Health and its agencies. I mean, we all pulled together to get polio kicked out of our communities. But really, in terms of the various diseases that we have to confront in the course of the next few years, it's not really a shortage of expertise. We do have people who know exactly what to do, but it's also being able to mobilize communities into implementing all of those interventions that are required. So, for example, issues around water and environmental sanitation, people knowing exactly what they need to do when it comes to protecting their kids from vaccine preventable diseases, making sure that at the appointed times that they are supposed to take their kids for vaccinations, having the right information about how to protect themselves from diseases. I mean, an example that we're already seeing is even with the COVID-19 outbreak, where we still have some community members, Nigerians, who don't believe that there's any pandemic of COVID-19, who think that it's all a ruse. So it bears very, very consistent risk communication. It requires that we provide the right information about how to promote health, how to influence decisions around health. And this is why in 2018, President Muhammadu Buhari launched the Community Health Influencers Promoters Services, a scheme that we're rolling out all across Nigeria that will ensure that in every community we have somebody who has been identified in the community that can provide the correct information about disease conditions and how to prevent them, making sure that in the next few years, once we have sort of put the footprints of these so-called CHIPS agents in our communities, they'll be there to also help with treating malaria after doing the rapid diagnostic test. So there are a number of factors that we have to contend with, but we're also seeing how our engagement with the traditional leaders, with religious leaders, is really becoming very, very fruitful, very, very critical towards our ability to eradicate polio, very instrumental in our rapid progress towards covering kids against vaccine preventable diseases, because these are the individuals who are providing the correct information to community members, so that community members know that from trusted sources they are getting information about the need to go for antenatal care when they are pregnant, and make sure that they have their deliveries within the confines of a health facility where they can be attended to by trained medical personnel. I think it does bear saying that this has been 5 years of really creative, innovative interventions in the health sector. But this does not mean that we are painting a rosy picture of everything being okay in the health sector. No, we still have a lot to do, and we still have the time to do it. But you can imagine that after several decades of neglect, for example, of primary healthcare centers, it's going to take some time. Investments like the Basic Healthcare Provision Fund, for us to move from -1, from below zero, to where we need to be. And that is the gradual step that we're taking. Like they say, the journey of 1,000 miles begins with one step. We've taken several steps in the last few years of the Buhari administration, and we're pretty confident that under the leadership of Mr. President and the Honorable Minister, we will actually be able to deliver as close as possible to what we would like to see in universal health coverage. We have up to 2030, but with every piece coming together, the vitalization of the primary healthcare centers, the insurance scheme being expanded and made mandatory, then it's easier for us to be able to reduce some of the unacceptable high levels of maternal and child deaths. Yes, progress is being made, but we are in a hurry. We're impatient with the current status, and I'm sure that everybody in the Federal Ministry of Health, the staff at the National Primary Healthcare Development Agency are working so hard to make sure that we reverse these trends.
All right, thank you very much, Dr. Shuaib. Once again, Professor Mohammed Nasir Sambo of the NHIS. Now, one of the widely reported issues about the NHIS before your tenure was the administrative crisis in that agency. Are you still in crisis? That's one. Secondly, one of the observable weaknesses of our health insurance scheme is the lack of cooperation, or if you like, support, complementary support by state governments. Very few states have their own health insurance schemes. Once in a rare while, you hear of a state that has launched theirs. What is the status now? So 2 issues for you to respond to. Are you still in crisis? And then health insurance schemes in the states.
Thank you very much, sir. When National Health Insurance Scheme was in crisis, everybody knows. Because you have a situation whereby it's reported in the media, both print and electronic. And you used to have a situation whereby security people will go with a tear gas throwing into it. And one of the key deliverable that I was given by the president is to restore peace in the National Health Insurance Scheme. And I'm sure, for especially you people in the media, you know that there is a stability in the National Health Insurance Scheme. No report of any crisis. We have been able to use our first rebranding agenda. When we came, we have a 3-point rebranding agenda. One is to restore value, to restore value system that will make NHIS to be a credible and result-oriented organization. And I can say with high degree of confidence that value reorientation has been very effective. We did not perform magic. What we did was to organize a retreat to be able to ascertain what are the major issues that will be bedeviling the organization, and we were able to get some organizational consultants to come up with about 10 key value system, which borders on issue that has to do with work ethics, ensuring discipline, ensuring synergy, unity of command, unity of direction, creating a very effective information education, communication mechanism within the system, and developing reward and sanctions for any erring a member of the organization. And we have deepened the implementation of those key issues, and now you have a very, very stable NHIS.
That's good. That's good to know.
Yeah, sorry, the other leg of the question, that's to say,
the other leg of the question is that health insurance in Nigeria is a decentralized system. We cannot have universal health coverage where only federal government is driving health insurance for the employees of the federal government. States have to key in to the program. But I'm happy to report here that all the states now have developed the social health insurance schemes, and we are working closely through a concept we developed, which is a concept of health insurance under our roof, where all the health people working in the health insurance ecosystem will come together under one platform. They are doing their thing, but we have a common binding force, which is which will integrate all the players through our ICT and through our effective health insurance management information system. We had a very successful retreat of the health insurance under our roof, where we developed a roadmap that will ensure attainment of universal health coverage. We have developed what we call matrix of coverage. where we streamline all the segment of the populations and of Nigerian population, the formal sector, the informal sector, the retirees, the elderly, the women under the women and children. We also have a program for the disabled people. So we have a global matrix which has been brought in by all the states, and we are now working.
That's very interesting.
Yes.
And it's good to know that the crisis, within your ranks have been resolved. But this might not fall within your purview, but I'm hoping that the NHIS will provide some form of oversight too on the HMOs who, render the service. There is also crisis of services. The enrollees consistently have complained about the quality of services they get when they go to access, healthcare, in terms of the quality of drugs that they are given, and in terms of, I don't want to say, segregation, class, distinction and things like that. Have you taken time to investigate and to probably oversight what is happening?
The first one that you wanted to ask about HMOs, it is within our 5U to regulate the function of HMOs. We register them, we issue certificate of operations for them, and any erring HMO we detect, we supposed to punish him, and there is the provision of punishment of any erring HMO is clearly encapsulated in our guideline.
What about the quality of drugs that are given to NHIS and release?
In fact, when I came, there was myriads of problems bedeviling the organization, and in fact, in one of the 101 session we have in this place, I have mentioned some of the things that we are doing. We have a two-pronged approach: the consolidation and the innovation. Under the consolidation for attainment of universal health coverage, we have what we looked at all the issues bedeviling the operations of the National Health Insurance Scheme. We had interaction with the enrollees, we had interaction with providers, we had interaction with HMOs, state health insurance, and numerous others, where we generated all the fundamental issues that are bedeviling the operations of health insurance. One of them is a quality issues, the access issue. Hitherto, health insurance scheme pay HMO on a monthly basis, and we recognize that there is usually a delay in the payment of fee to HMO, and thereby there is a delay in the payment of healthcare providers. And when there is a delay in the payment of healthcare providers, our enrollees will return back because payment has not been effected. We organize that payment system. We now do pay quarterly, and ever since we started in January, there is no reported case of an enrollee being returned. So one of the problem is addressed. The issue of drugs. The last time NHIS has undertaken a review of tariff was 2012. And you know the amount of inflation that has taken place. And the health insurance scheme has no unlimited fund. But we must have to address that problem. So the strategy we employed, we brought all the manufacturers, drug manufacturers, companies in Nigeria, and discussed how they can manufacture drugs of quality nature for the purpose of the teaming enrollees within the National Health Insurance Scheme. And just yesterday, we finalized all the discussion. And if you remember PTF system, during under the chairmanship of our current president, when drugs were produced with inscription of PTF. Yes. So this is the kind of agreement we have entered into with manufacturers. All the drugs that are within the benefit package of the National Health Insurance Scheme, the manufacturers have agreed that they will produce with NHIS inscription. All right. So wherever you go, you will get that and inscribed drug.
All right. Professor Sambo, thanks a lot. We're going to have to pause you. I want to go back to Dr. Obe Adigwe. You've seen him on the screen for a while. Dr. Adigwe, you left hanging one of the last points you wanted to make. You may wish to make that point, but I want to throw in this question as well. Pharmaceutical research and development isn't cheap. How has funding been? I know that you will cry and say that you need more money, but how has funding been, and how creative can it possibly be to fund pharmaceutical research and development?
Yes, just before we went on the break, Claire had asked that we move from frameworks and models to tangibles. And it was as if I preempted that question, because I actually came with a number of tangibles for Claire. And this particular product, before this administration, government had an agreement with a foreign manufacturer to produce this product. This product is one of the top 5 worldwide for sickle cell. And that particular collaboration with a foreign company did not work. When this government came in place, one of the first things that this administration did, and it was spearheaded by Minister Hanire, who's seated there in the studio with you, was to now identify a local manufacturing company to partner with government as regards bringing this product back in a way that you have assurance of the quality, you have assurance of the price, you have assurance of the sustainability of the value chain. And even though we've not come to launch this particular product, it is my pleasure to now tell Nigerians that NIPRID and government bent over backwards to deliver this product, because it's a key example of how we can achieve improving access to medicines in Nigeria if we align with the ontological position of this particular administration. We had to rekit my drug manufacturing unit in the National Institute for Pharmaceutical Research and Development. That unit was assessed by NAFDAC, got NAFDAC approval. We've been manufacturing there, and we've been supporting that local manufacturer. And you can clearly see the very high quality of the product that has come out. Wholly Nigerian product with raw materials that are derived from phytomedicines harnessed here in Nigeria. And usually health isn't very tangible. And that's why people struggle to see the value. But it pleases us when these type of results come out and we're able to present it so people can identify the work that has gone on for years behind the scenes. Earlier on, somebody also mentioned quality.
Dr. Adigwe, I'm sorry, if we check your time, we're almost done with our program, but of course not before allowing the Honorable Minister. The health sector is a very wide sector. I mean, we can't exhaust all that discussions, but thank you for that. That was what Nigerians wanted to see. So, Kingsley, you have a question for the
Honorable Minister. One of the issues that you confronted as Minister of Health or Minister of State for Health, drug abuse. At some point in Kano, it was reported that the addicts were consuming some 2 million bottles of codeine syrup per day. And of course, the government rolled out a number of measures. What are the numbers now? Have they declined significantly, or they are climbing?
Well, the codeine part of it, most of the medicines, most of the codeine quantities that companies had to be sequestered, taken out of circulation, where government is paying compensation for taking out of circulation. The figures have declined for drug abuse and drug addiction. The part of the response is in building centers where you can attend to those who have become addicts. And just a few days ago, I was writing to the governor of one of our states who's helping to build and staff a center where we can address drug addiction. But it's surprising that actually that is what becomes a problem.
It's right. We have just less than a minute to wind up. We'd like to appreciate you, honestly. That's the Honorable Minister of Health, Dr. Osage Ehanire. of course, joining us on Good Morning Nigeria today. Thank you very much, Honorable Minister.
Thank you very much.
We'd also like to appreciate Dr. Faisal Shuaibu, Executive Director and Chief Executive Officer, National Primary Healthcare Development Agency. Thank you, Dr. Shuaibu, for joining us.
Thank you very much.
And Dr. Of course, Professor Professor Mohammed Nasri Sambu, Executive Secretary of the National Health Insurance Scheme, NHIS. Thank you very much. Dr. Obi Adigwe, we've already thanked you. Director General, National Institute for Pharmaceutical Research and Development, NIPRD. Gentlemen, we'd like to appreciate your presence on Good Morning Nigeria for today. Kingsley.
All right. Indeed, that does it for us on the program. We thank you for being with us. We're back on Monday, same time, 7 o'clock in the morning. Until then, enjoy your weekend. Remember to stay safe and be well. I'm Kingsley Sadolo.
Bye-bye.